Good evening, ladies and gentlemen, and thank you for joining our live webinar today on Thrombophilia Revisited, a changing approach to diagnosis. My name is Dr. Vineet Nair, and I'll be your moderator for today's event. I would like you to remind everyone that today's webinar is interactive, and we encourage you to participate by submitting as many questions as you want at any time you want during the presentation. To submit a question, simply type the question into the chat box to your right and click send. At the end of the presentation, we'll be having a Q&A session. If you have any trouble seeing or hearing the presentation, please use the chat box to let us know that you're experiencing a problem. With this webinar, we will be giving certificates of attendance. All those who complete the webinars and wish to be provided with the certificate must fill a form which we will provide to you at the end of the webinar. This form only asks for your email as well as your name and title as you want it to appear on the certificate. I'd now like to introduce our speaker, Dr. Amar Dasgupta, pre-eminent hematopathologist and Director of Medical Services at Suburban Diagnostics. Over the past 4 decades, he's had a storied career in hematopathology at institutions like the Postgraduate Institute for Medical Education and Research in Chandigarh, Tata Memorial Hospital in Mumbai, the University of Washington, Seattle, Hammersmith Hospital, London, Hinduja Hospital, Mumbai, and SRL Diagnostics, Mumbai. A fellow of the International Union Against Cancer and of the Indian Society of Hematology and Blood Transfusion, he has over 125 published scientific papers in national and international journals, and was responsible for setting up India's first hybridoma laboratory and India's first cytometry laboratory way back in 1995. Without further ado, let me hand over the reins of this webinar to Dr. Raj Gupta. Over to you, sir.
Thank you, Vineet, for the kind introduction. Friends, indeed, it's a pleasure to be able to interact with you and talk on a topic which, as I see and many of you must have realized, has undergone quantum change in terms of its understanding as well as the diagnostic approach that we follow when we compare that with maybe 2 to 3 decades back. So I thought this would be a very good topic to discuss today in our presentation. So as I've entitled this presentation, I'm talking mainly about the changing approach to diagnosis. But before that, and as I go through it, you'll realize that even today there are a lot of ambiguities in our the various indications, in fact, and the groups or the patient groups that we ought to investigate. The different authors, different publications, different data give somewhat, sometimes even conflicting, inferences, and therefore the matter is still sub judice, I would say. But there are certain clear ideas that have emerged till now, and I'll be dwelling on these, largely. So what I intend to do is to go through these following points, namely, what is thrombophilia, when do we suspect thrombophilia in a patient, cause of thrombophilia or causes of thrombophilia, prevalence of thrombophilia and relevant or relative risk estimates, clinical considerations, who should be tested and when, test panels and algorithms for testing, and finally the take-home messages. So as most of you would know, thrombophilia, that term is derived from 2 words in Greece, or in Greek rather, which is thrombo and philia. Philia, as we know, is affinity for something, and thrombo, of course, indicates thrombosis. So thrombophilia tells us that there is an increased affinity or predisposition to venous thrombosis in patients who acquire or rather inherit certain abnormalities. So thrombophilia is an inherited or acquired abnormality of hemostasis predisposing to venous thrombosis. Now, the words venous thrombosis are important because when we talk of thrombophilia, we talk of only thrombosis of the venous system and not of the arterial system. That is because the mechanisms that are involved in genesis of arterial thrombosis are very different from those of venous thrombosis or thromboembolism, as we commonly call it. Although there could be some factors which are common to both, and we'll look at those as we go along. So why does one become prone to thrombosis? And this is a favorite slide of mine, which I always show to emphasize that even though we have procoagulant and anticoagulant or fibrinolytic forces in the system, in our body, inside the blood vessels, there is a balance, and that balance is in fact tilted in favor of the anticoagulant and fibrinolytic forces. And as a result of that, the blood that we have in our blood vessels does not clot, or does not clot repeatedly, but remains in a liquid state, and therefore it's able to do its job, which is carrying oxygen and various other nutrients and immune cells and whatnot to the most remote periphery of our body. So this is a point, therefore, to remember. And therefore, if there is an imbalance in the pre-existing equation that we have in our body, that will lead to increased either bleeding tendency or thrombosis. But here we are talking about thrombosis, and therefore thrombosis happens when there's a decrease in the level or activity of natural anticoagulants, which I have mentioned earlier, or the fibrinolytic pathway. Of course, fibrinolytic pathway abnormalities are not so common. Very good examples of deficiency or decreased activity of normal or natural anticoagulants is deficiency of protein C, Proteinus, and Antithrombin. Or alternatively, there is an increase in the level or activity of procoagulant proteins, for example, factor VIII, which recently, or maybe a decade back, has been recognized to be a major factor in determining the etiopathogenesis of venous thrombosis. So this is an example of genetically or acquired elevation of a coagulation factor, in this case factor VIII, which can give rise to enhanced procoagulant activity, and therefore tilts the balance, or rather neutralizes the balance which is tilted in favor of fibrinolysis, or what is responsible for the blood to remain in a liquid state, and therefore thrombosis happens. Or there could be an excess of activated factors, and as we all know, the procoagulant factors in circulation are nothing but most of the coagulation factors which spontaneously, as a part of day-to-day activities, get activated. And these activated factors are in fact neutralized or acted upon by the anticoagulants, natural anticoagulants, and fibrinolytic pathway to take care of the generation of the procoagulant proteins and prevent thrombosis. So if there is an action, there is an excess of activated factors, for example, factor V, as happens in factor V Leiden, which is because of the mutation in the factor V protein, the activated protein C system is not able to cleave it, and therefore the factor V continues to remain activated in large quantities in circulation and renders the system more prone to thrombosis. And this is an example of gain of function. So this same thing is depicted in a diagrammatic manner here. As you can see here, normal liquid blood is because of the higher activity or predominant activity of the natural anticoagulants and fibrinolytic pathway, which in turn inactivate the procoagulants and thrombin generation as well as fibrin formation. And because of that, the accumulation of these thrombotic substances is taken care of, and therefore the blood doesn't clot normally. But if you have an imbalance in this delicate balance that we have, wherein there is increase in the procoagulant forces and leading to thrombin generation and fibrin formation. The natural anticoagulants and fibrinolytic pathways get overwhelmed, and you have generation of thrombin and thrombus formation as a result of fibrin formation and stabilization of fibrin. So this is the same thing in a diagrammatic manner, and this is something which we have to keep in mind as we go along to understand the the various aspects of diagnosis and management of these patients. So again, this is a very well-known kind of slide or facts which give us the features which suggest the possibility of thrombophilia in a patient of venous thrombosis or deep vein thrombosis. If the patient is in early age, in the age group of less than 45 or less than 50, and has got a venous thrombosis, I think that should point towards the possibility of a inherent thrombophilia or an acquired thrombophilia. Purpura fulminans, which is a unique entity which happens in patients usually with Proteinus deficiency. When these patients are put on warfarin, they develop skin necrosis, and that is due to the fact that warfarin causes further reduction in production of protein C in these patients, and it enhances the thrombotic process further and leads to necrosis of the skin supplied by the blood vessels which are thrombosed. Superficial or deep vein thrombosis and pulmonary embolism with a strong family history. Recurrent thrombosis during anticoagulation, which are very strong indicators of predisposition to venous thrombosis. Thrombosis of unusual venous circulation, say for example, cerebral, hepatic, mesenteric, and renal veins, which normally we do not see as the sites of thrombosis, but in thrombophilia, these are the areas which get thrombosed preferentially. So when you see that, you suspect that the patient could have thrombophilia. Then other sites like arm, portal, and ovarian veins. Some cases, as I mentioned, some cases of arterial thrombosis can also happen as a result of defects in the thrombotic and anticoagulant pathways. Although the mechanism normally in arterial thrombosis involves the blood vessel wall, atherosclerosis, and of course platelets, which normally are not involved in venous thrombosis. Recurrent fetal loss is an indicator for possible lupus anticoagulant, and therefore one should suspect that in a woman who is having this problem. Complications of pregnancy in terms of intrauterine growth retardation, stillbirth, severe eclampsia, abruptio placentae, and things like that. So when you come across a patient who falls, or rather shows these features, one should then suspect that these patients could have a predisposition to thrombus formation, and therefore should be handled in that manner. Now, this is a very important slide which shows how even if you have tendency inherited or acquired to increased tendency to venous thrombosis, you would not have the the thrombus formation manifesting itself in clinical terms. In other words, you may have a predisposition, but you will not be manifesting in terms of DVT and pulmonary embolism. But because for that to happen, between the acquired and inherited thrombophilic predispositions. So the interactions could be between inherited, between acquired, or between inherited and acquired. And this is a very important point to keep in mind. And therefore, just because somebody inherits a defect, which will lead to, or theoretically will lead to increased tendency to thrombus formation, does not necessarily translate into clinical thrombosis unless and until there are other factors which superimpose on them, or they interact with the pre-existing factors. So this is something which we have to keep in mind. And in most instances, it is a combination of inherited predisposition which gets precipitated by an acquired condition which also predisposes to venous thrombosis. And when you have this kind of a combination, you have manifest venous thrombosis. So this is something which we have to keep in mind, and you'll see examples of that as we go along. So when we talk about the causes of thrombophilia, we have been speaking about the inherited thrombophilias and acquired conditions which can give rise to increased tendency to thrombus formation, and there would be, of course, a mixture of the two, or conditions where both operate. The examples of acquired thrombophilia or conditions where thrombophilia is acquired or there is increased tendency to venous thrombosis are listed here, and amongst them the most important acquired thrombophilic condition is what we call as APLA syndrome, or antiphospholipid antibody syndrome, of which lupus anticoagulant, of course, is a manifestation, is one of the indicators. And then you have very common situations like obesity, immobilization, major surgery, trauma, bone fracture, and then a host of things, including various hormones, particularly female hormones, replacement therapy with hormones, and then, of course, some of the hematological disorders like myeloproliferative neoplasms, PNH, and of course, not listed here are the malignancies. All of these conditions render the patient more prone to thrombosis. Now, if such a patient already has an inherited predisposition as indicated here, in terms of antithrombin deficiency, protein C deficiency, Proteinus, factor V Leiden mutation, prothrombin gene mutation, and dysphagia, any of these inherited predispositions, if a patient has that and then he undergoes these situations, then it is very likely that that patient will have a manifest DVT or venous thrombosis or pulmonary embolism. And that is the point which is shown beautifully in this diagram. And this is something which we have to keep in mind. The significance of that, of course, you can realize, and we'll also look at in the subsequent slides. Factor VIII, I did mention about as one of the factors which is responsible and has been recognized recently as a cause of increased tendency to venous thrombosis, or gives rise to increased tendency to venous thrombosis, can be inherited, wherein because of genetic mutation you have a very high level of factor VIII anyway, or it can increase as a result of underlying infection, inflammation, malignancy, because it's also an acute phase reactant like many other proteins. So a person who has inherited any of these deficiencies has now elevated factor VIII, will have a very high risk of developing venous thrombosis if he has the elevation of factor VIII. So this would also be another example, and there are other examples listed here, but they're not so common, so I'll not get into that. Only mention that homocystinemia or hyperhomocystinemia is a condition which can be acquired or it can be inherited, and therefore this is listed as mixed. And this is something which we have to keep in mind, because deficiency of vitamin B12, vitamin B6 can give rise to acquired elevation of homocysteine in circulation. And although theoretically that would predispose a patient to venous thrombosis if that person has already inherited any of the thrombogenic conditions, but nutritional deficiency of vitamins giving rise to hyperhomocysteemia, which in turn gives rise to venous thrombosis, is not not reported. So I think the elevation here of homocysteine as a result of deficiency of vitamins is more of academic importance and more of a diagnostic challenge when one comes across elevated homocysteine level in a lab. So this is just to keep oneself aware of this fact, and as I said, it doesn't carry that kind of significance unless it is inherited, where the levels go high up, and then that of course is a cause for both venous as well as arterial thrombosis. This is one of the causes of venous and arterial thrombosis, like Aplar syndrome. So these are the two conditions in which you get both venous as well as arterial thrombosis. Now, quickly go through two pathways which are important for us to understand why in protein C deficiency we have, or for that matter in factor V Leiden or mutation or protein S deficiency, we have increased tendency to venous thrombosis. As you can see here, the endothelium, which is painted in pink, is a very rich source of thrombomodulin, which when endothelium gets activated, it liberates or it exudes thrombomodulin on the surface, or its expression, the expression of thrombomodulin increases, which is a very strong attractant for thrombin, which is normally being generated in the system, as I mentioned, as a part of normal hemostatic mechanism. And whenever that complex takes place, it binds protein C. So protein C has a tendency to get bound to thrombin thrombomodulin complex. And when that happens, in the presence of protein S, protein C gets activated. Activation means there is enzymatic action of protein S on protein C, and that converts protein C into activated protein C, which in turn inactivates activated factor V and activated factor VIII. Now, therefore, you can imagine that if you have an altered factor V, which happens in factor V Leiden gene mutation, altered means is mutated. So if the mutation is at a site where activated protein C acts normally to inactivate activated factor V, the activated factor V will not get inactivated. And more of factor V, activated factor V, will be collecting or accumulating in the circulation. And the same thing happens also with factor VIII. And as a result of that, you have a marked excess of two very strong procoagulants in the system. And that in turn drives the thrombotic pathway and leads to thrombin generation and fibrin formation. So therefore, you can imagine that if you have deficiency of protein C, if you have deficiency of protein S, and or factor V mutation or factor VIII mutation, which is very rare, you will have a tendency to increase production of activated factors, factor V and factor VIII, and as a result of which you will get venous thrombosis. So this mechanism is very important, and they are therefore interrelated. And some of the assays like APC resistance screening assay that we do is based on this, this reaction, and therefore it can tell you, depending on if you do a one-stage or two-stage assay, whether the patient is likely to be protein C, protein S deficient, if the patient has activated protein C resistance, or it's likely to be a mutated factor V. Or factor V Leiden. So that is possible for us to do. So this understanding is very, very important. And the next one is regarding the mechanism of action of antithrombin, which, as you can see here, antithrombin is a very powerful antithrombotic protein, and it acts as you can see, mainly in the intrinsic pathway, wherein it inactivates the contact factor, factor 11, activated contact factor, factor 11A, factor 9A, factor 10A, and of course thrombin. And as a result of that, this is very, very powerful anticoagulant in the system in vivo. And deficiency of these, of the antithrombin per se, gives rise to a very high tendency to venous thrombosis, as well as recurrence of venous thrombosis. So antithrombin 3 deficiency compared to protein C or Proteinus deficiency is a stronger thrombogenic etiology in the inherited thrombophilia group. So this is something which we should also keep in mind. This table shows you the salient features of antithrombin protein C and Proteinus deficiencies. As we know, it can be type 1 or type 2. Type 1 is quantitative deficiency, type 2 is functional deficiency. And in the case of Proteinus deficiency, because you have a free and a bound component of the protein, you have a type 3 as well, wherein the bound part is normal, but the free part or free protein S decreases. As I mentioned already, highest risk of thrombosis is out of these 3 is associated with antithrombin deficiency. Interestingly, protein C deficiency or protein C levels are related to age and sex. Females have lower protein C levels, as well as older people have lower protein C levels, and therefore they have a higher tendency of developing venous thrombosis if for any reason due to inherited or acquired the level goes down further. So this is something which is important, and therefore the level of protein C is usually and even protein S should be interpreted against the gender of the patient, if not age at least. So I think this is something which we should remember, and the labs should report accordingly. And this role of antithrombin, as I mentioned, is shown here again, that you have the first risk of or relative risk of first venous thrombosis 5 to 10 times compared to the others where you have a little or lower risk. The case of recurrent venous thrombosis, the risk here again, as you can see, is higher. So this is just to tell you the point that I was making earlier, that antithrombin deficiency is something which one should be wary of compared to the other deficiencies. Although lupus anticoagulant is in a way more notorious than antithrombin, but that's not an inherited deficiency, as we just now learned, and it is again something which has to be handled in a little different way. So a common challenge that people in the lab face is the request for doing thrombophilia screening or thrombophilia testing in a patient of DVT or pulmonary embolism before starting the therapy or at the time of presentation. And as common sense will tell us, and of course the knowledge of thrombosis and hemostasis, that it doesn't make any sense to do these investigations in patients who have just presented with the manifestations of DVT or pulmonary embolism. The reason for that are here. The cause of DVT and pulmonary embolism does not influence the management strategy. In other words, the anticoagulant therapy is the same irrespective of the cause, and therefore there is no point doing a screening for the cause of thrombophilia at the time of presentation of the patient. The results of all coagulation-based assays are likely to be fallacious, as the various coagulation factors and natural anticoagulants are being consumed in the ongoing process of thrombus formation. And this again you can appreciate very well. And therefore, when you do all these assays, thrombophilia assays, at the time of presentation, you are liable to get erroneous results because these proteins are actively being used up, broken down, and all kinds of things are happening, and therefore the results are not likely to be representative. So there's no point doing these assays at that point in time. The decision for long-term anticoagulation in most of these cases also does not depend on the results of initial screening, and therefore it doesn't make any sense. And although all of us who work in labs and who interact with our clinical colleagues on a daily basis, we realize how much pressure we have to face to negate or deny doing these tests at the time of presentation. But this is an ongoing battle, and I think all of you must be aware of that. But one has to explain this to the clinical colleagues that indeed it doesn't make any sense to do that, because you are not going to be benefiting, or the patient is not going to be benefiting out of the information that we'll get at this point in time. So how do we decide? I mean, these are the areas that I was referring to earlier, where we have these dilemmas and then ambiguities in terms of what is the right way to approach the problem. So if we know the goal of testing, why are we testing, what is the objective, then maybe it is possible for us to rationalize the testing protocols, the time of testing, as well as the panel of tests, or the kind of a mix of tests that we intend to do. So the things to consider while deciding about the objective of testing would be to decide whether it's going to aid in decision making regarding the future venous thromboembolism prophylaxis against recurrence. I think recurrence is something which all of us are worried about in patients of DVT, because on one side we do realize that there is no need for testing up front the patients when they come with venous thrombosis, because of the reasons I just now enumerated. But it's very important to decide after having put the patient on anticoagulation, which normally, as per the standard protocols, are carried on for 3 to 6 months, depending on the the clinical condition, the severity of the disease, the family background, the family history, and all those things. But the question arises after that as to what do we do? Do we continue with the anticoagulation beyond 3 to 6 months, or do we stop? And this is what we need to take into account when we are planning the testing. So testing, anyway, if at all has to be done, it has to be done only after 3 to 6 months of anticoagulation. And this is a point which has to be understood by everybody. So, as I said, there's no point doing testing during or before or at the time of presentation of the disease, but to decide whether you want to continue with anticoagulation, what would be the implication of the disease in terms of inheritance of similar problem by the relatives of the patient who may have to undergo a procedure. So those are the issues which one will have to consider before deciding about the investigations. So the point I'm making is no investigation at presentation, no investigation during the anticoagulation, first initial anticoagulation, no investigation even after that, unless you have a clear objective or goal in terms of what you want to know by doing the test in terms of further management of the patient. So first point we just now dwelt on. The next one is if it is helping to guide us in testing of family members, especially regarding risks associated with oral contraceptive therapy and pregnancy in female family members. So this is the singular most important group that we should keep in mind in terms of investigating the patient as well as the family members of the patient. And female family members of patients who have inherited thrombophilia and have manifested as DVT would be a good candidate for investigating for the risk of inherited thrombophilia, especially if these women or ladies are planning to go on oral contraceptives or are planning a child. So this is the most clear-cut indication of thrombophilia testing in the patient and the relatives of the patient. Other than that, there are very few where you would need that, except some situations which I'll be sharing with you a little later. The goal also should be to determine the cause. In case it is, especially in these situations, as just now I was mentioning, of severe venous thromboembolism, fatal venous thromboembolism in family members, and thromboembolism in unusual locations. So there you would like to know whether the patient has any inherited thrombophilia or not, and what is the the underlying mechanism which has given rise to this kind of unusual manifestations. And test results alone should not be used for decision making regarding duration of anticoagulant therapy. So as I just now was emphasizing, that this is not the lone or single indication of continuing with the anticoagulation therapy in these patients. There are many other clinical and background considerations that need to be taken into mind before one decides about investigating these patients after stoppage of anticoagulation. So the corollary to that, of course, would be that do not test for cause of thrombophilia at the time of VTE event, which we have just now discussed about. But in case there is a compelling reason, I would be contradicting myself if I say that yes, there would be compelling reasons. But in case one believes that, there is a way of doing that, what we call as two-step screening strategy, which I'll dwell upon in the next slide maybe. And you can follow that. In other words, this what it does is it allows, or it kind of legalizes or legitimizes the screening of these patients using tests which are not influenced by the thrombotic process, and therefore you can do those tests even at the time of presentation or during anticoagulation therapy. Secondly, while patient is receiving anticoagulation therapy, of course you cannot or you should not be doing any of these assays, particularly those which are based on anticoagulation, or rather based on coagulation assays. And if venous thromboembolism is provoked by strong risk factors, then of course you do not need to do testing, because these are likely to be, and these cases are likely to be due to multiple acquired factors and not due to inherited factors. And therefore, testing for inherited thrombophilic factors will not make sense in these cases. So, as I said, there will be some examples where you may like to do screening for the cause of venous thrombosis after the first VTE, and that is in patients in whom the VTE occurs at a young age in association with weak provoking factors, indicating that this person is very likely to have an inherited thrombophilic factor or thrombophilic cause, and you may like to investigate to know that upfront so that you can advise the family members accordingly. Cases of unprovoked VTE, again, unprovoked means when you do not have a reason for venous thrombosis. You do come across such cases, and although I did mention that in most of the instances you will have interplay of thrombophilic factors giving rise to venous thrombosis. Presence of one or the other does not necessarily lead to venous thrombosis, but there could be cases where perceptibly the patient didn't have any precipitating factor or any underlying factor and gets venous thrombosis. Those cases you may like to know. patients with VT at unusual sites, just now we referred to, and patients with a strong family history of VT and inherited thrombophilia, or those having recurrent VT, and again, family members or female family members in the childbearing age. So these are the cases where after the first venous thromboembolism has been tackled and has been managed with anticoagulation for 3 to 6 months, you may consider doing the investigations to advise or come to know about the possible, the etiology, so that the long-term management can be better taken care of. So the same thing has been shown here, so I'll not get into the details of this in this flow chart. Coming to recurrent venous thromboembolism, which is, as I said, is the main concern after you have managed the patient's first episode. So what are these considerations in terms of deciding about continued, anticoagulation, or restarting a patient on anticoagulation after stopping? So those decisions will depend on these considerations. And of course, again, the incidence of or risk of recurrent venous thromboembolism after the first episode is highly variably reported. I've taken the maximum, which is 30%, which of course is a significant incidence in terms of recurrence of VT in these patients. This risk has to be looked at. I mean, this has to be assessed. And if in the opinion of the treating physician, the risk is low, then the continuation or restarting of the anticoagulation is not justified or is not done. And therefore, this is largely a clinical decision. Lab testing has very little role to play here. And this is therefore not an universal, rule that just because there is a risk of thrombosis, recurrence of thrombosis, that invariably, therefore, we have to put a patient on, continuation of anticoagulation or, restarting of the anticoagulation. This risk is higher in patients with unprovoked than those with provoked VT. That means the risk of recurrence is higher with unprovoked than with provoked venous thromboembolism. Baseline parameters related to the risk of recurrent venous thromboembolism are the proximal location of deep vein thrombosis, obesity, old age, male sex, and non-O blood group patients, whereas the role of inherited thrombophilia is controversial. And that's the point being mentioned in the top. And as you can see here, the clinical assessment of the patient at this stage becomes very, very important. And the ultrasonographic evidence of residual thrombosis in the veins, things like D-dimer estimation at that point in time, at the end of 3 months or 6 months when you are contemplating a stoppage, those are more important or clinically more relevant parameters in determining the recurrence of thrombosis than the results of these investigations are. Continuing with the clinical considerations, the persistence of residual venous thrombosis at ultrasound assessment, that's the point I just now made. Persistently high values of D-dimer and the early development of a post-thrombotic syndrome have consistently been shown to increase the risk of recurrent venous thromboembolism. So this highlights the point that now is being appreciated, is that the decision, as I have been repeatedly telling, to continue with continue with anticoagulation does not depend on the results of thrombophilia screening, although it may give you additional information which may help you fine-tune the approach that is being followed after 3 to 6 months of therapy. So these are very important realizations that have come to light in recent times. and therefore I thought I'll share this with you. And that, what does it mean? It means that the need for investigations, and therefore the initial enthusiasm about doing these assays in patients of deep vein thrombosis is not justified, and realization of that is slowly bringing down the request for such tests. And I don't know, definitely it's good for the patients and the clinicians. So definitely something which we in the laboratories need to be aware of, and guide the physicians on the right track rather than mislead them. So this is very, very important for us to realize. Strategies that incorporate the assessment of residual venous thrombosis and D-dimer have the potential to identify subjects in whom anticoagulation can be safely discontinued. One of the challenges in terms of continuing anticoagulation for a long period, or the risks that one anticipates, is the risk of bleeding. And in all studies, it has been shown that patients of DVT, when put on long-term anticoagulation, have a definite, although not a very high risk, of bleeding. Now, the problem arises with the long-acting or the conventional anti-vitamin K anticoagulants like warfarin, is that the effect doesn't go away fast, and therefore, in case of bleeding, the reversal of bleeding is a big challenge, clinical challenge. So, in light of now the availability of short-acting anticoagulants like the newer anti-10A, anti-2A, as well as the various newer forms of heparin, they give us the advantage that you can, in the case of bleeding, you can stop the drug immediately, and the bleeding gets reversed in 24 to 48 hours maximum. So this is something which is changing also the need or the realization that you don't have to worry so much about the bleeding, and therefore the freedom to use anticoagulation is definitely much more today than when we had only oral anticoagulants in the form of warfarin and other oral anticoagulants. So again, to make a point that when should the test be performed, which is again at the end of the day very, very important. Do not perform the thrombophilia testing at the time of VTE diagnosis or during the initial 3-month course of anticoagulation therapy. So I have labored hard on this point, and therefore I need not repeat that. So it is very obvious. Why 3 months? 3 months is in the context of the oral anticoagulants, which are conventional, like vitamin K antagonists, warfarin and others, because of this problem that vitamin K antagonists will lower the levels of some of these natural anticoagulants like protein C and Proteinus. It will also lower some of the liver-dependent coagulation factors like factor 2, 5, 7, 9, and 10. So these this has to be kept in mind, and therefore you don't do these tests in patients who are on anticoagulants, and if you have to do it, then you have to stop it for 3 months, which is again impractical, because if the patient has risk of thrombosis or recurrent thrombosis, waiting for 3 months doesn't make sense. So this again loses its significance. And if at all you have to do, you can follow the 2-stage testing which I just now mentioned, which, as I said, will involve, which is I think given in the next slide, tests such as factor V Leiden, prothrombin gene mutation, cardiolipin, and beta-2 glycoprotein 1 antibodies, because these are not influenced by abnormalities of coagulation, which happens in patients who are taking warfarin. Of course, the tests which are dependent on clotting or clotting-based assays, you cannot do in patients who have had anticoagulation. So they will have to be deferred till you stop anticoagulation till for 3 months at least. And that is the recommendation, which again, as I said, is impractical. So now quickly I will finish the various tests that we do. I have listed a cost-effective screening panel for thrombophilia, which consists of PT and APTT, just to know that the patient does not have any other issues such as a prolonged APTT, which is not corrected by normal plasma could suggest, and a normal PT could suggest presence of lupus anticoagulant. If both are abnormal and badly abnormal, then integrity of the sample can be a question, because other types of anticoagulants. So doing a PT and APTT as a first level screening of patients' samples before embarking on the other expensive assays is a good step. So we should always do that. Fibrinogen level will tell us, of course, with thrombin time, the possibility of dysfibrinogenemia, where you can get increased tendency to venous thrombosis. Factor VIII activity, test for lupus anticoagulant, and that I'm talking about the screening test. And of course, if positive, go to anti-cardiolipin, anti-prothrombin, or anti-beta-2 glycoprotein 1 assays, antibody assays. Protein C should be functional assay. Protein S should be free protein S immunoturbidometric assay. Antithrombin functional, usually chromogenic, and factor V Leiden. Incidentally, you will notice that I have not listed prothrombin gene mutation, because that is extremely rare in India. There are very maybe occasional cases reported. So it doesn't make sense to include that in the initial screening or cost-effective screening panel. There are various general principles of precaution that we should take into account before embarking on thrombophilia testing, and the patient should be advised accordingly. Blood sample should be collected preferably on empty stomach, because if you are using an optical instrument for measuring endpoint of clotting, then this is not going to be a good sample because of the turbidity following food. So this is something which we have to keep in mind. Doesn't make big difference in optomechanical or mechanical systems. Anticoagulation should be off for up to 3 months, as already mentioned, and of course 1 to 2 days for the newer anticoagulants. Hyperhomocystinemia I referred to can happen because of deficiency of these vitamins, should be kept in mind. Multiple aliquots of platelet-free plasma should be frozen down so that you can do batch assays. Doing these assays individually is not practical and not cost effective, and therefore all labs do freeze samples down for batching them up. Screening coagulation tests recommended, as I mentioned, mainly APTT and sorry for the mistake, and PT, and look at the correction by normal plasma to infer whether the sample is suitable for going ahead with the rest of the tests or not. Thrombin time is recommended to detect dysfibrinogenemia and heparin contamination, which can be a problem in patients who are admitted in the ICUs or in the wards because of the presence of venous lines. So this has to be kept in mind. Functional assay of antithrombin and Potency, which we have already mentioned. PCR using test plasma mixed with factor V deficient plasma and 2-stage assay is what is recommended. Not a very popular test nowadays. We normally straight away go to factor V Leiden gene mutation studies and don't do an APCR. But still some people ask. Comprehensive assay for antiphospholipid antibodies should be performed. Laboratories must establish their own reference ranges and cutoffs with respect to the RVVT, because borrowing these ranges and cutoffs from other labs or using the kit insert is not the right way, because the interpretation of the test will depend on that. And if you do not have your own cutoffs, your results are going to be erroneous, or interpretation will be erroneous. and of course, stringent quality assurance exercises should be a part of day-to-day activity in all coagulation labs. This is the next two slides will give you the algorithm that one can follow in patients where thrombophilia screening requests have been made. So you do an APTT. If APTT is abnormal, that is prolonged and gets corrected, then you do not go ahead with the thrombophilia screening, because it means that there is either acquired or inherited deficiency of coagulation factors, more likely to be acquired due to integrity issues of the sample. If it remains uncorrected, it could be things like anticoagulants, heparin, and NOACs and DOACs. But you certainly would like to rule out lupus anticoagulant, and therefore you do a screening for lupus anticoagulant. And if that indicates the presence of lupus anticoagulant, then of course go ahead and do the entire panel for APLAS investigation. If the APTT is normal, which should be the case in most of these scenarios, then do a two-step APCR, which I said is not a popular test nowadays. The slide is a little old, therefore that time I had included it. But it does help you distinguish between cases of protein C and Proteinus deficiency, depending on which step of the assay is abnormal, and factor V Leiden. But then finally you'll have to confirm these by doing these specific assays. So you cannot escape that, and therefore one may question the role of two-step APCR. Going forward, protein C activity, if normal, it's okay. I mean, patient is not deficient. Abnormal, then do also a protein C antigen level by ELISA to characterize the deficiency correctly. Free protein S, okay, done. Antithrombin, if normal or abnormal, then if it is abnormal, then again do an antigen assay. Homocysteine normal, no issue. If it's abnormal, then patient should be given vitamin B6, B12 supplement. If it gets corrected, then it's likely to be nutritional. If not corrected, then likely to be inherited due to the deficiency of this enzyme, methyl tetrahydrofolate reductase, which is required for conversion of homocysteine to methionine in the synthesis of DNA. So in the absence of the vitamin that I refer to, vitamin B12 and B6, you have this pathway defective, and therefore you get elevated homocysteine level in these people. Factor VIII activity would be optional, but no more now. It is a part of a panel because of the realization that factor VIII is very, very important in terms of pathogenesis of thrombophilia. And of course, fibrinogen assay level, as well as a thrombin time, which I mentioned earlier, will give you the diagnosis of high dysfibrinogenemia. So before we get on to the take-home messages, this diagram just shows you how the trend in thrombophilia screening and management has changed over time. When in the 90s, the testing of family members and relatives and all that we are today emphasizing on, the reasons I have explained, was very little. The emphasis was more on testing extensively patients and erroneously at wrong time, and therefore resulting in a huge number of tests being ordered, and that much more load on the labs. From there, we have gone to a level where there is very little testing that is requested or should be requested now, because of the reasons I explained, while the focus is shifting to investigating the patients. Here it says about the arterial thrombosis and pregnancy complications. But as I showed you, the investigation of family members, the potential risk to them, and those issues are more important, and therefore are being focused at, rather than indiscriminate testing as used to happen earlier. So this is a trend which has changed, and awareness of this is very, very important. And in fact, it has happened because of the awareness amongst clinical colleagues that there has to be a judicious use of these investigations for managing these patients. And finally, the take-home messages. Testing for thrombophilia has a limited role in the management of DVT and in deciding about the duration of anticoagulation, and should not be performed casually. Thrombophilia testing in asymptomatic relatives may be useful in families with antithrombin, Potency, and Proteinus deficiencies, or for siblings or patients who are homozygous for factor V Leiden, and is limited to women who intend to become pregnant or those who would like to use oral contraceptives. Observational studies show that patients who have had VTE and have thrombophilia are at most at a slightly increased risk of recurrence. This is the point I was dwelling on at length. No beneficial effect on the risk of recurrent venous thromboembolism was observed in patients who had been tested for inherited thrombophilia. Anyway, that doesn't make any sense anyway. Diagnosing APLA syndrome in women with recurrent miscarriages usually leads to treatment with aspirin and low molecular weight heparin, although the evidence to support this treatment is also limited. This is going beyond Potency, Proteinus, Antithrombin deficiencies. The right time to investigate a patient with unprovoked DVT is after 3 months anticoagulation. If anticoagulation is by conventional anticoagulants the point I made earlier, or stoppage of anticoagulation for 1 to 3 months. This again applies to the same, but now with the use of newer anticoagulants and heparin derivatives, the withdrawal period can be 1 to 3 days, not 1 to 3 months, and that's an advantage. D-dimer level post cessation of anticoagulation has an important role in deciding about the continuation of anticoagulation after 3 months. I think that's all I had to share with you. Thank you all very much for your attention and time.
Thank you, sir, for that amazing presentation. We'll now be also collecting the details of attendees for the certificate. If you look at the chat box, you will notice a link has been posted. Kindly click this link and enter your details exactly how you want it on the certificate. Once you have entered these details and submitted the form, you will receive a certificate of attendance in your email inbox. Once again, sir, that was an amazing presentation. We have a few questions I think we can cover quickly before we wind up for today. So one of the questions that has been asked is, in the case of protein C and protein S, which is better to test, antigen or activity?
In case of protein S, it should be the free protein S, which is actually directly related to the active moiety of protein S, because protein S circulates in blood in two forms, free and bound. It's bound to complement 4 binding protein, and that is not available for action. And therefore, the free protein S assay, which is actually an antigenic assay, it's immunoturbidometric assay, and therefore it can be, that's the one which should be done. And in case of protein C, yes, it has to be functional.
Okay, sir. Another 2 questions which I'll club together because they are roughly around about the same thing is related to COVID-19. So one person has asked whether the thrombosis in COVID-19 could be due to pre-existing or undiagnosed thrombophilia conditions. And another person has asked is whether the higher levels of F8, homocysteine, protein C83 could be correlated with what's happening in the COVID pathogenesis. Basically, what they want to know is is there any link between pre-existing conditions of thrombophilia with the current COVID situation, mortality that we're seeing in the COVID situation?
Yeah, that's a very good question, but I think it's a bit conjectural to connect the two. If you are aware, the thrombotic episode in COVID-19 infection, what we call as VITT, is actually is generated, or the pathogenesis is platelet driven, and it's like heparin-induced thrombocytopenic purpura or thrombotic thrombocytopenia. And there also the platelet factor 4, which is liberated by activated platelets as a result of activation by the various inflammatory reagents or inflammatory or pro-inflammatory mediators in COVID is in the at the base of the pathogenesis. So the thrombotic process also is mainly arterial in COVID, but I think it is possible that injury to the particularly homocysteine, which is directly injuries to the endothelial lining of blood vessel, and if that is high, a person has an inherited hyperhomocystinemia, definitely that person will be more prone to the thrombotic, the outcome or the effects of thrombotic episode in COVID-19 infection. But patients who have acquired hyperhomocystinemia, as I was explaining earlier, due to vitamin deficiency, vitamin B12 or B6 deficiency, the level is not to the extent which will cause endothelial injury, and therefore predisposition to more severe thrombotic episode in COVID-19 infection because of acquired hyperhomocystinemia due to vitamin deficiency would be a little far-fetched kind of a extrapolation. So I would say that it is possible, but I don't know if any published data is available. I'm not aware of any, so that would be my answer. I would say it is sub judice at this point in time.
Fair enough, sir. So one other question that's come is, person has asked what exactly would be the the pathogenesis of what happens in Sneddon's disease.
In
Sneddon's disease, SNEDDONS, Sneddon's disease. Sneddon's disease, yes.
What is that? I'm not aware of it.
I think it's an inflammatory vasculopathy, if I'm not mistaken. We'll get back to this. I think we can email the reply to this particular candidate. Sure. And one last question for us before we wind up for today is there any relationship between inherited thrombophilia and infertility?
And infertility?
Yes.
Yes, there is. There are reports of that, and in fact, in the case of females, definitely there is some association reported. The fact that the lesion in lupus anticoagulant, particularly in Aplar syndrome, involve the blood vessels, and it is seen in the postmortem examination of the placentas in patients of recurrent abortion and things like that, and of course also in complicated pregnancies, that that could be responsible for endometrial vasculopathy as well, or uterine vasculopathy, and therefore possibility of infertility is also there. But I'm not very sure if there are other mechanisms involved in this. This is an interesting question. Yes, thank you.
Thank you, sir. Thank you for that excellent session. That's all the time we have for now. I'd like to thank all the attendees for joining us today and for their interesting questions. In reply to many of the messages that they've been, we will be emailing you a link to the recording of this webinar within 24 to 48 hours. You will be able to watch the webinar at your convenience. Please feel free to forward the link to your colleagues who may have missed today's sessions. So I again want to thank Dr. Amar Dasgupta and again all the attendees. Everybody, please stay safe and have a good evening.
Thank you. Thank you very much.